speaking on ocular surface tumors, and it will be a blessing for all the postgraduates to hear to him. I will take this opportunity to introduce him, but before that, I would also like to welcome Dr. Vikas Khetan, who will be moderating the session, who is a senior consultant at Sankara Nethralaya, Chennai. Dr. Santosh Honavar needs absolutely no introduction. As you guys grow up in ophthalmology, you will realize what a big name Dr. Santosh Honavar is. But as part of the protocol, I have to complete this. He is the editor for Indian Journal of Ophthalmology, and he is the director for medical services for Center for Sight Group. And this is the second term in his Indian Journal of Ophthalmology as editor. And he did so well, and he took the journal to such great heights that for the second term, he had no opponent and he got elected unopposed, which is a rarity in All India Ophthalmic Society elections. He is the director of the Department of Ocular Oncology and Oculoplasty at Center for Sight in Hyderabad presently, and he is the director for National Retinoblastoma Foundation. He is the former head of the Department of Ophthalmic Plastic Surgery and Ocular Oncology, and he was the associate director at LV Prasad Eye Institute, and he is known for his research on retinoblastoma not only in India but globally. The Council for Scientific and Industrial Research, the apex agency of Government of India for scientific research, awarded him the Shanti Swarup Bhatnagar Prize for Science and Technology, one of the highest Indian science awards for his contribution to medical sciences in 2009. Apart from the many articles and journals that he has written and the several awards that he has won in All India Ophthalmic Society, apart from the several orations that he has given around the country, one of the biggest awards that he recently received in the last 6 months to 1 year was from the American Academy, and he is the only Indian to have received the very prestigious coveted American Academy Life Achievement Honor Award. It's such a blessing and honor to have you, sir, with us. I would like to request Dr. Santosh Honavar to please make his presentation on ocular surface tumors, please.
Thank you, Satyajit. It was a very generous introduction, I would say. Thank you so much. Thank you for the honor of having me here. I'll be speaking on ocular surface tumors. I'll be sharing my slides. Are my slides seen?
Yes. Yes. Okay. Perfect.
All right. I'll be talking about ocular surface tumors. It may not be too important from the point of view of exams, but there is life beyond exams. That is, all of you are going to practice ophthalmology. And from that perspective, these become important. And why should you know about them? Well, of course, it can be a theory question in the exam and you might have a spotter, etc. But you should know about ocular surface tumors because these are the most common tumors of the eye and adnexa. Among all the other tumors that eye and adnexa can have, ocular surface tumors are the most common, especially in a tropical country such as India. And they're very easy to diagnose because these tumors are actually staring at you, begging for a diagnosis. They're not hidden somewhere that you have to do a scan to diagnose them. They are very evident on naked eye and obviously on slit lamp evaluation. Yet, 30 to 40% of these are misdiagnosed. So while they're easy to diagnose, the chance of misdiagnosis is as high as 30 to 40%. And they're extremely easy to treat also. There is no high technology that is required to treat simple microsurgical techniques with oncological basis. Yet 20 to 30% of them have local tumor recurrence, which may have regional lymph node metastasis later and systemic metastasis and can be lethal, especially in melanoma. So this is a kind of contradictory situation where tumor, which is so easy to diagnose and easy to treat, can yet be misdiagnosed and can be inappropriately managed. Let's go through the list of these tumors. Choristoma is not a tumor by definition, but it is included because it behaves and presents like a benign mass. Epithelial tumors, melanocytic tumors, vascular, fibrous, neural, xanthomatous, and myxomatous, lymphoid tumors, and secondary tumors. This is the laundry list of conjunctival tumors. Now let's start with choristoma. Choristoma is a congenital entity and there are 4 variants: dermoid, dermolipoma, osseous choristoma, and complex choristoma. This is a typical limbal dermoid. Dermoid on the ocular surface, the most common variant is a limbal dermoid, presents with limbus as the epicenter and has corneal as well as episcleral extension. So its center will always be at the limbus with corneal and scleral extension, and it could be asymmetric. Sometimes the corneal component is much larger, sometimes the scleral component is much larger. Now, issue with limbal dermoid is that it can cause astigmatism. It can be unsightly because of its infero-nasal infrotemporal location, and also because it grows hairs. It could cause symptoms to these children who have it. It can cause ocular irritation, epiphora, redness, etc. Sometimes it goes into the stroma quite deep, and in such situation, you'll find this sign, hydration at the leading edge of the lesion. So this indicates clinically that this particular tumor is deeper in the stroma, and when you excise it, you might be very careful. Otherwise, you will have tectonic issues with the cornea, or you might keep a lamellar graft standing by in case you have tectonic issues. So that's about the limbal dermoids, causes astigmatism and amblyopia. That's one of the reasons why it can be removed early. The other association that you have is with a syndrome. This, of course, you're very familiar, and the association is that you have preauricular appendages and also spinal abnormalities. Now, the second issue with dermoid is that it can be, as I said, it can be predominantly corneal. Now, if it's predominantly corneal, this is called a corneal dermoid. This is often associated with anterior segment dysgenesis and thus have visual morbidity. So even when you completely excise it, you will need a penetrating keratoplasty that often fails. And because these children have associated anterior segment abnormality, there is always a visual morbidity that is associated with corneal dermoid, if not deep amblyopia. The third variant is a dermolipoma. Now, dermolipoma presents generally in the supratemporal aspect, and it is almost always associated with a palpebral lobe of the lacrimal gland. It doesn't infiltrate, but it is all around the palpebral lobe of the lacrimal gland. A very typical feature is that when it touches the ocular surface, it creates a crevice. Suppose it overhangs the ocular surface, there is this crevice. That is what you see here. It does not join the ocular surface or merge with the ocular surface in all the areas. That's a very typical feature of a dermolipoma, as opposed to a fat prolapse, which is seen in stocky, short-necked, heavy-built individuals who are elderly, and it is more pinkish, and it is kind of like a more globular in appearance, and it is also supratemporal and often merges with the surface of the eye. Now, this is the differences between a dermolipoma and a prolapsed fat. Prolapsed fat is bilateral, whereas dermolipoma is more commonly unilateral. But a different location such as infronasal, as you see here, does not rule out a dermolipoma. It can also occur in the infronasal aspect. And if you have a case with dermolipoma, we are often worried that, okay, if we excise it, we may cause diplopia because you might injure the lateral rectus and also the lacrimal gland. The trick here is to keep your dissection plane anterior to the tenons because it is subconjunctival. It does not involve the tenons. That the pink tissue that you see there is the lacrimal gland. So your incision should be away from the lacrimal gland. Then you go subconjunctivally and anterior to the tenons, so that you don't even see the lateral rectus muscle. And as it merges laterally along the lateral canthus, when it gets into the orbit, it has a very narrow neck. That is when you truncate it and excise it. So basically you excise where it joins the orbit and excise the narrow neck. Rest of it will retract into the orbit and will not generally recur. So that's how you excise it. A very simple excision where you don't injure the palpebral lobe of the lacrimal gland and the lateral rectus. That pink tissue that you see is the full thickness conjunctival involvement. And how do you repair the ocular surface? You can repair it with a conjunctival graft or a amniotic membrane which is glued on in position. So this gives good cosmesis and also does not cause any functional problem. The third variant of choristoma is a osseous choristoma. Now, osseous choristoma, as the name indicates, contains osseous elements, and this is generally deep-seated in the sclera. So when you excise a osseous choristoma, you have to be careful because the osseous component will suddenly come off the corneal stroma and sclera and will leave a deep crater which can have tectonic issues again. So when you have a patient with osseous choristoma, you have to be ready with a tectonic graft such as a sclerocorneal graft to fill that area and give support to the wall of the eye. The fourth variant is a glandular choristoma. Now, again, as the name indicates, it contains glandular elements, so it is secretory. So it can be very subtle and can form small cysts containing secretions like this. And when you excise it, you'll come to know that it is a glandular choristoma containing lacrimal gland elements. So all choristomas are present at birth. So there is no confusion at all in the diagnosis because child is born with it. It may be very small when the child is born, but over a period of time, it may increase in size. So the last variant is a complex choristoma. So complex choristoma contains almost all the elements. That is why it is called a complex choristoma. It can have osseous element, it can have epidermal elements, it can have stromal elements, it can have anything for that matter. So it has some association that you should be aware of, one of which is a cutaneous tag. So it is associated with cutaneous tag and subcutaneous osseous or glandular elements. It can be associated with a lid coloboma, as you see here, which is a very shallow coloboma. It is often bilateral. And when you look at these children on their neck, chest, and abdomen, they will have nevi. And when you look at their scalp, you'll find bald patches. So it's called nevus sebaceous of Yardison. So unlike other choristomas, which don't have any dangerous systemic implications, nevus sebaceous of Yardison is dangerous because it can be associated with systemic malignancy, basal, squamous, and sebaceous cell carcinomas. And also these children have visual implications because this can have an associated osseous component in the choroid, in the sclera, and if it is located in the macular or juxtapapillary area, it will have visual implications as well. So when you have nevus sebaceous of Yardison, you have to completely evaluate these children for systemic associations. Going on to epithelial tumors. Now this is the simple classification of epithelial tumors. Squamous epithelial tumors, benign, could be papilloma, and hereditary benign intraepithelial dyskeratosis is seen in only a minority of triracial individuals, Navajo Indians as they call it in the United States. That is not of our concern. And in pre-malignant and malignant component, we have ocular surface squamous neoplasia. There are other epithelial tumors also I'll show. So this is a very typical conjunctival papilloma. It can occur on the bulbar conjunctiva and also palpebral conjunctiva. It is caused by human papillomavirus infection and is often recurrent. So the characteristic of a conjunctival papilloma is that it tends to recur if it is incompletely excised, and it can come back in different parts of the ocular surface because it's of viral etiology, and virus is diffuse. It does not stay at a single place. Now, the problem with conjunctival papilloma is that it very easily merges with ocular surface squamous neoplasia in terms of its morphology. Sometimes it looks exactly like ocular surface squamous neoplasia with huge blood vessels, episcleral and conjunctival feeder vessels, and also intrinsic vascularity. So there is a blur between clinical diagnosis of conjunctival papilloma and ocular surface squamous neoplasia. And as you would know, HPV infection also causes squamous cell carcinoma. So sometimes papilloma can convert to squamous cell carcinoma. Like this is a very typical example where a pre-existing papilloma has converted to squamous cell carcinoma, and it can also be pigmented because Indian or Asian Indians have a tendency to acquire secondary pigmentation. This is a typical papilloma with a central vasculature and radiating blood vessels, whereas this particular component is darkly pigmented and it is actually looking like a conjunctival melanoma. Now, how do you treat papillomas? One way of treating it is excision and cryotherapy of the edges and the base. That works well. But if it's very diffuse like this, or if it is recurrent, then you can immunomodulate these patients by using either interferon, cimetidine orally, or levamisole. These are immunomodulating agents. Cimetidine is used here for its immunomodulating action. So this was one such child where there was a large papilloma which was recurrent, and this child was treated with interferon with good success. This is a diffuse papilloma in a Mongolian. You can see intranasal extension of the papilloma as well, and he settled down after excising it and treating him with interferon. So interferon works well in papillomas. The next variant of papilloma is called an inverted papilloma. Now, generally papillomas are supposed to be like this with a small pedicle and the base attached. Now, what if a papilloma has a small apex and a large deeper base like this? You can see a small apex and a large deeper base. So this is called inverted papilloma, and it has a very high predisposition to develop into squamous cell carcinoma. So whenever you see papilloma test changes on the surface, but it has a deep component, you should be worried for the patient and completely excise it. Going on to other epithelial tumors, this patient has unilateral red eye and has flat or placoid lesion on the ocular surface. So whenever a patient comes with this kind of unilateral blepharoconjunctivitis, you should always flip the lid and look at the lid margin and the palpebral conjunctiva. Here you see that this is the normal thickness of the eyelid, whereas rest of the eyelid is nearly 2 to 3 times thickened, and the posterior lid margin, which is supposed to be sharp, is all rounded, and eyelashes are sparse. So these are features of sebaceous gland carcinoma, and this is the epithelial extension of sebaceous gland carcinoma called pegytoid extension. So this is also a conjunctival epithelial tumor without much of eyelid tumor to uh, evaluate. I mean, there is not much of eyelid tumor component, although it is very subtle, predominantly presents with bulbar and palpebral conjunctival involvement, pegytoid sebaceous gland carcinoma. Next, going on to ocular surface squamous neoplasia, which is the most common conjunctival malignancy in tropical countries, generally occurs in older males. Now, OSSN is not a malignant lesion in the sense that it is a spectrum. When somebody says OSSN, it does not mean that all these patients with OSSN have a malignant lesion, because it's a clinical spectrum comprising of dysplasia, carcinoma in situ, and invasive squamous cell carcinoma. Out of these, only invasive squamous cell carcinoma is a malignant lesion, whereas this is borderline and dysplasia is a precursor. Dysplasia is further classified as mild when the cellular thickness that is involved is 1/3. Moderate is up to 3/4 of thickness. Severe dysplasia is when full thickness of the epithelium is involved, and carcinoma in situ is when full thickness epithelium is involved with the loss of surface layer. Beyond that, it becomes invasive squamous cell carcinoma. Now, what is the etiology for OSSN? The most famous etiology is limbal transition zone theory and stem cell theory. Now, limbal transition zone is a zone where there are stem cells, and if a particular stem cell goes bad, it goes on proliferating without limit, and that often is stimulated by ultraviolet B radiation, which is cumulative radiation. Lifetime radiation of ultraviolet rays is what sets off change in the limbal stem cells. So it's not a one-time radiation such as that you get when you do collagen cross-linking. No, that will not cause OSSN. But if somebody is exposed to UV radiation for all through his life, maybe an outdoor worker or an agricultural laborer, they tend to develop it. P53 induced mechanisms, where you really don't need much of UVB radiation. If the patient already has a predisposition, he will develop. And human papillomavirus infection. But if a patient is immunocompromised, such as patient is HIV seropositive or has post-organ transplantation immunosuppression, or is using topical steroids for a very long time, resulting in local immune suppression, or on systemic steroids, then these patients can also develop ocular surface squamous neoplasia. Now, what are the symptoms? An evident growth is a symptom. Patient may come to you saying that he has a spot or a growth on the surface of the eye. Because of its rough surface, patients can have foreign body sensation. Patients can have redness, which may be because of increased vascularity itself. The eye will appear red. And if it is growing over the pupillary axis, then patients will have defective vision. Sometimes it's picked up on a routine evaluation without any symptom at all. Now, what is the location of these lesions? Most common location is perilimbal and interpalpable. So basically about 60 to 70% of them will be in this location, perilimbal, temporal, interpalpebral location, bulbar conjunctiva of course. And almost all of them, when they have a limbal lesion, will have some amount of corneal involvement. Now corneal involvement can be epithelial, can be up to Bowman's membrane, can be stromal or even full thickness. Now, depending on the morphology, the way a lesion appears, it can be further classified as gelatinous. That means it has a gelatinous appearance, a waxy gelatinous appearance. Papilliform, it looks like a papilloma with multiple radiating blood vessels like this. Velvety is something, it looks like a sheet of velvet. Leukoplakia is when there is keratin predominant, and it can be nodular and diffuse. For example, this is a nodular lesion and this is a diffuse lesion. Diffuse is when the thickness is less than 20% of the overall diameter. So if it's a flat lesion, that is diffuse lesion. But if it's elevated like this, then it's called a nodular lesion. So these are the morphological variants. Now one more morphological variant specific to Asian Indians or Asians or Africans is a pigmented variant. So this can cause diagnostic dilemma because this can mimic a pigmented conjunctival lesion such as a nevus or a melanoma. Now, these are the morphological variant of ocular surface squamous neoplasia, which I already talked to you about. And what is most important, more important than that, would be to recognize the masquerades, such as patients presenting with unilateral blepharoconjunctivitis, patients presenting what looks like a corneal scar, but have a very small conjunctival component, a large corneal epithelial component, looks like a corneal scar. Patient presenting like Moran's ulcer with a peripheral corneal gutter, but a keratinized lesion and a scleral component is obvious. Patients presenting with what looks like sterile corneal melt, maybe you may consider rheumatoid arthritis, etc., but actually that is tumor-induced necrosis. And also patients who have a necrotizing scleritis kind of a picture. These are the masquerades. So look at this slide very carefully. Each tumor has a different morphology. That means that it is not uniformly, it doesn't uniformly have same clinical features. It varies in its clinical appearance, and masquerades of course vary grossly in clinical appearance. So you need to know which one is a OSSN and which one is not. That is the diagnostic problem actually. That is the reason when somebody is seeing a patient with OSSN in a regular comprehensive ophthalmology practice, only 1/3 of them are diagnosed as OSSN. In fact, 2/3 of them are diagnosed as other simulating conditions, essentially because it looks so different. Look at this and look at this. They're so different. So we should have very good diagnostic criteria. And what are those diagnostic criteria? We depend on two features. Number one is keratin. Number two is abnormal vascularity. So why does keratin more important? Keratin is important because any rapidly proliferating epithelial tumor with a very rapid epithelial cell turnover produces keratin as a byproduct. And vascularity is something that is inherent to these tumors, both feeder vessels which supply the tumor and inherent or intrinsic vascularity. So let's look at the diagnostic advantage of these features. If a particular conjunctival lesion, it may look like a pterygium, pincula, inflammation, flicton, anything. If it has keratin, then it is 80% sensitive and 92% specific for the diagnosis of OSSN. Apart from keratin, if there is abnormal vasculature, episcleral vessels supplying the tumor and intrinsic vascularity, then you are very good in diagnosing OSSN, 93% sensitive and 95% specific. Very good diagnostic accuracy. If you want to be further more accurate, then you bring in rose Bengal staining. All these pink areas are stained with rose Bengal. So if a particular conjunctival lesion has keratin, has abnormal vascularity, and also stains with rose Bengal, then you have almost 100%, 97 and 98% sensitivity and specificity in diagnosing OSSN. So you're almost as good as the gold standard, that is histopathology. So whenever you have a conjunctival lesion and it looks even slightly atypical, you have to go through this checklist. And if at all it meets the checklist, then clinically you diagnose it as OSSN and treat it as such and send it for histopathology. If you're still confused, then we currently have OCT. Anterior segment OCT is the diagnostic tool that is currently used. And what are the features? This is normal corneal epithelium, which is grayish and about 70 micron thick. Now look at the adjoining lesion. It is hyperplastic and hyperreflective. Hyperplastic because it's as high as 500 micron, and obviously it is not grayish, it is whitish, it is hyperreflective, and it is also causing posterior shadowing because of its density, and it abruptly truncates. You see this snout abrupt truncation of hyperplastic hyperreflective corneal epithelium is the diagnostic sign of OSSN. So with all this, there should be no difficulty at all in diagnosing ocular surface squamous neoplasia in the clinic. Now, OCT also helps us in many ways. It not only diagnoses the tumor, but also tells us the thickness of the tumor, which is important from the perspective of surgery, and also tells us what plane to dissect when you do surgery. Example, this is a histopath correlation of the same tumor. You can see that we have dissected up to tenons. We haven't touched the sclera. There was no need at all because this particular tumor is not involving the sclera. It is just involving the conjunctiva, and you take one more barrier, that is tenons, and it is completely excised. You will get a negative margin. This is a UBM, which is showing us that this particular tumor, you can see the normal stroma here. It is playing the corneal stroma. That means corneal stroma is thickened and widened, indicating full thickness involvement of the corneal stroma. So you will definitely need either plaque brachytherapy or a corneal graft in this patient when you operate. The fallacy of these imaging modalities is that if there is dense keratin, there is posterior shadowing, thus precluding assessment of the depth and extent of the lesion. Now, what are the systemic associations of OSSN? Xeroderma pigmentosum, HIV seropositivity, post-organ transplantation, iatrogenic immunosuppression, and palmoplantar keratoderma are the four known systemic associations of OSSN. Of course, now what is coming up is VKC. VKC is also supposed to be a precursor or a predisposing factor for OSSN. Now, the classification. Well, I told you morphological classification already, but what is currently used for research purposes and also to categorize treatment is TNM classification, which is a simple classification, tumor node metastasis classification, and this is what we currently follow. Now, coming to melanocytic tumors. Now, melanocytic tumors are further classified as this: nevus, primary acquired melanosis, and malignant melanoma. Now, primary acquired melanosis can be with atypia or without atypia. Malignant melanoma can arise de novo from a pre-existing nevus, from a primary acquired melanosis, or can be syndromic, such as mole melanoma syndrome. Now, when you look at the data, what is important to know is the incidence in a given number of patients. How many tend to be melanocytic? Well, we don't have good Indian data, but the Western data shows that about 50% of conjunctival tumors are melanocytic. And when you further look at that, about a quarter of them are actually nevi. So nevus is supposed to be the most common conjunctival lesion, followed by benign, of course, followed by primary acquired melanosis in about 12% and melanoma in about 12%. That makes about 50%. Now, this is a set of pictures where there are 4 different patients with nevi, and each one looks different, yet you are supposed to diagnose it. So we use again for nevus a clinical checklist. Nevi are interpalpebral in location. Very rare examples are there where the nevi can be located in the superior or inferior bulbar conjunctiva. Nevi are supposed to have variable pigmentation. If you look at this carefully, you'll find all shades of brown, dark brown here and light tan brown there. So nevi are variably pigmented, whereas melanoma is uniformly darkly pigmented. Nevi don't have corneal epithelial invasion. They generally don't go onto the cornea. If you look at this, you may find that it is slightly overhanging the cornea, but that is not corneal epithelial invasion. A typical corneal epithelium invasion would look like this: wavy edges of pigmentation and vascularity carried forward to the cornea. That doesn't happen in a nevus. Nevi also don't have episcleral fixation. That means that if you move a nevus on the slit lamp with a wet cotton tipped applicator, nevi moves on the episcleral surface, whereas melanoma has fixity. Nevi do have feeder vessels. This is not a diagnostic uh, contraindication. That means that if a patient has a feeder vessel like this, it doesn't mean that it is a melanoma. But if a patient has a lot of blood vessels within the lesion, then you may have to reconsider your diagnosis of a nevus. Microcyst is the most important feature. And if you can't see microcyst on slit lamp, then you can do UBM or ASOCT. You find this microcyst or sometimes a large coalescing macrocyst. These are microcysts and these are large coalescing macrocysts. So that's a very, very typical feature of a nevus, whereas melanoma is more compact and solid. Example is this patient where this teenager has a amelanotic lesion slightly transgressing the limbus with one single large feeder vessel and what looks like a lot of intrinsic vascularity. Now you have a diagnostic dilemma because it's non-pigmented. So how do you know what it is? Simply do imaging, and if you find microcysts, then it is sure that it is a amelanotic nevus. Now, if you look at the data, you find that pigmentation is a, not a universal feature of a nevus. In fact, 15% of nevi are non-pigmented. Cysts are very common. 65% of these nevi have cysts on clinical examination. OCT data is not yet out. If you do OCT, then maybe nearly 98% or 99% of patients will have cysts. And if you do a raster and scan the entire lesion, then I can bet that 100% of nevi will have some cyst at some location. So cysts are universal in nevi, but on slit lamp only about 65% are observed to have a cyst. But is cyst pathognomonic of a nevus, which means that every patient who has a microcyst has a nevus if it's perilimbal? No, that is not true, because lymphangiectasia, lymphangioma, and mucoepidermoid squamous cell carcinoma can also have cysts. And going by the literature again, most common location of the nevus is bulbar conjunctiva, followed by caruncle, plica, etc. Whereas if you have a pharyngeal, tarsal, and a corneal lesion, most likely it is not a nevus or it is extremely rare. Now, nevi can grow into a melanoma, and if it's a amelanotic nevus, it can go into a fleshy amelanotic melanoma. So how common is the transformation? So when you see a patient in the OPD, you can tell them that 1 in 300 or 3 in 1000 patients with a nevus over their lifetime can transform into a melanoma. So what happens when there is transformation? When there is transformation, first thing is that the cysts are lost. There is loss of cyst. Second is that there is intense change in color. From light pink, it can go to fleshy pink. From lightly pigmented, variable pigmented lesion, it can go to dark brown like this. Like you see here, this is a nevus which this patient always had since he was a child. Now it has transformed into a melanoma. You can see change in, this is nevus still, change in color, dark brown, and also fleshy pink. And the patient has subconjunctival hemorrhage. Look at it carefully. There is increased vascularity. So these are the features that a patient has. When this nevus turns into a melanoma, it brings in a lot of blood vessels to feed this hungry tumor. So it is elevated, nodular, fleshy with prominent blood vessels and intrinsic vascularity. Now, when you do imaging in these patients, you find that the cysts are still there in the nevus component. So this patient had both nevus and a melanoma, you remember? And in the area where there is melanoma, there is solid tumor. So basically, this is the line of transition, LOC, between a nevus and a melanoma. So a nevus has evolved into a melanoma. Nevus retain the cyst, whereas melanoma lacks the cyst on imaging. So this is one good way of assessing a lesion, whether it has turned into a melanoma or not. Now, if you have a patient with conjunctival melanoma what is the chance that they will have systemic metastasis, and what are their origin. In fact, primary acquired melanosis has the highest contribution to melanoma. Nevus is very low and about 20% of them arise de novo. And if it's a de novo melanoma, then that has the highest chance of systemic metastasis. So that will help you tell the patient that if a patient presents like this without any precursor lesion and has a melanoma, that patient has almost half the chance that the patient may develop systemic metastasis. These are some of the variants of conjunctival melanoma. This is extremely nodular with scleral invasion. Now, whenever you have a patient with a pigmented conjunctival lesion, it is imperative that you evaluate the entire ocular surface. This is a picture from Dr. Shields where you see that there is a caruncular lesion, but when she flipped the lid, you see that there is a palpebral conjunctival lesion as well. So it is not a nevus that the patient has in the plica caruncle, it's actually a multifocal melanoma. Some of the differential diagnosis for what looks like a melanoma is a balloon cell nevus. This is actually a congenital condition, extremely benign, but looks very scarily like a nevus, but it is completely accessible. So look at the kind of scary appearance that it has, but it is just a balloon cell nevus. Other differential diagnosis is a pigmented ocular surface squamous neoplasia manifested with keratin. Now, the third differential diagnosis is extraocular extension of a uveal melanoma. This patient has a ciliary body melanoma you see here and iridotrabecular involvement, and that's an extraocular extension which looks like a conjunctival nevus. Now, patients with pigmentary disorders such as vitiligo can have amelanotic melanoma. Amelanotic melanoma is also common in Caucasians or patients with light iris and blonde hair, but it can also happen in Asians when they have pigmentary disorders. Now, what is the other differential diagnosis for a conjunctival pigmented lesion? It's classified as actinic melanosis. Actinic melanosis is when a patient is exposed to ultraviolet radiation, there is conjunctival pigmentation. It is almost always bilateral because whenever a patient is exposed to UV radiation, it is bilateral. So when something is bilateral and nearly symmetrical and the patient gives a history of actinic exposure, then that is actinic. Second is racial melanosis or complexion associated melanosis. This is seen in Asians and Africans where because of their complexion, there is associated conjunctival pigmentation and that can be exacerbated by actinic exposure. Third is reactive melanosis. Now, what is reactive melanosis? Obviously, as a reaction to chronic irritation. It could be because of chronic use of medication that irritates the ocular surface, chronic use of, or for example, VKC, where there is chronic inflammation or chronic conjunctivitis. All these can lead to reactive melanosis. Now, depository. Depository is a melanosis where patients use cosmetics around the eye, such as mascara. So, mascara can get deposited in the conjunctiva and can cause conjunctival melanocytic lesion. Or adrenochrome containing anti-glaucoma medication such as Epithelial, which was earlier available, can also cause conjunctival pigmentation. Then finally, primary acquired melanosis. Now, this is a racial melanosis or complexion associated melanosis where patients come with very characteristic pigmentation of the conjunctiva. It is bilateral, often symmetrical, and it has this cobblestone kind of an architecture. You see nice cobblestone kind of an architecture here. And fine pigmentation can extend to the peripheral cornea. As you see here, it can go deep into the fornix and it can have very minimal tarsal involvement. But what is characteristic is bilaterality. If a patient comes to you like this, bilateral, symmetrical or asymmetrical conjunctival pigmentation, then you don't worry about these patients. It is complexion or racial melanosis. But if a patient has what looks like complexion associated melanosis, but the other eye is quite white, or there is gross asymmetry, other eye has only mild pigmentation, then you worry about these patients because these tend to be primary acquired melanosis. So asymmetry is a feature of primary acquired melanosis, and you should look for other areas in the conjunctiva, such as palpebral conjunctiva and the pharyngeal conjunctiva, because these tend to be multifocal and diffuse. So whenever a patient who is middle-aged has unilateral flat pigmentation with no cysts, then that is PAM, and that has a highest risk for melanoma. So this tends to be peppery, like a dusting of pigmentation which are grouped together, unlike racial melanosis where there will be cobblestone kind of an architecture. So very, very typical clinical appearance. You see the nice peppery nature of primary acquired melanosis. Again, primary acquired melanosis, which is peppery. So what is the risk of PAM developing into melanoma? We always believed in this 1982 study by Armed Forces Institute of Pathology, which had a small number, but they told us that there is a very high risk, overall about 30%, and when there is atypia, about 45%. But now the Wills series, which has a much larger number, shows us that the risk is there, but not as high, whereas without atypia, the risk is 0%. With atypia, the risk is about 13%. We should be worried, but not so much. But then whenever a patient has PAM with atypia, we should completely excise it. So how do you know that a particular patient has PAM with atypia or not clinically? It's very difficult to tell. So you go by other corroborative signs, such as the extent of the lesion. If a lesion is more than 1 clock hour, then the risk of it developing into a melanoma or having atypia increases. So if a patient has 1 clock hour involvement, you simply watch, you don't do anything. Just mark that area, take a picture. Again, 1 clock hour involvement or 1.5 clock hour involvement, less than 2 clock hours, simply watch, no treatment. But if it is peppery and more than 2 clock hours, for example, this is about 5 clock hours, then you definitely want to excise it completely and treat. Now, other corroborating features are if a lesion is more than 10 millimeter, and when you look at it on slit lamp, if there is certain amount of thickness that is associated with it, if there is intrinsic vascularity or feeder vessel and corneal epithelial invasion, and when you stain it, it stains with fluorescein, that means there is surface ulceration, then you might want to excise it. Now, one more new terminology that is associated with primary acquired melanosis is conjunctival intraepithelial melanocytic lesion, or SEMEN. That is not very universal at this point in time. Now, also you should be worried about PAM when it extends to tarsal conjunctiva like this, or pharyngeal conjunctiva, or involves plica and caruncle. So you can see some examples here. This is PAM with atypia involving the inferior pharyngeal conjunctiva. Now on the medial side is a melanoma. This is a PAM in the pharyngeal conjunctiva, and you see a nodule, that is melanoma. So when PAM happens to a patient, you should be concerned about that patient, and you should be worried about it to the extent that you should excise it and do a good histopathology. And adjuvant treatment is mandatory if it turns out to be PAM with atypia. Now, which conjunctival lesion should you be worried about? Definitely not this. This is racial melanosis. It's bilateral and has cobblestone kind of a appearance. If it's peppery like this, extending to about 6, 7, 8 clock hours unilateral, that is PAM, and you should be worried about. If it's a small pigmented lesion in the temporal bulbar conjunctiva, perilimbal in location with one feeder vessel and no intrinsic vessel, and non-uniform pigmentation, it's a nevus, not to be worried about. But if it's a similar location but has a fleshy appearance with lot of blood vessels, then you should be worried about, because it's a melanoma. Let's go on to vascular tumors pretty quickly. Vascular tumors can be further classified as AV malformation, capillary hemangioma, cavernous hemangioma, lymphangioma, capaces, and exuberant granulation. This is a typical arteriovenous malformation of the epibulbar surface. And when you have such a patient, if you ask them to do Valsalva, if there is any periocular swelling or if there is proptosis, then that confirms the diagnosis of orbital varices. That's an example of an acquired conjunctival capillary hemangioma, which is very rare but can present with multifocal channels, vascular channels in the conjunctiva. This can be unifocal or multifocal, and it can be simply excised. When you have clear cysts in the conjunctiva with some kind of a epithelial debris within it, that is a lymphangiectasia. Lymphangiectasia is not really lymphangioma, but these patients can land up with subconjunctival, spontaneous subconjunctival hemorrhage. This is a very typical lymphangioma, which is a fleshy pink vascular lesion in one of the fornices or on the bulbar conjunctiva. Now that is also conjunctival lymphangioma. It looks very scary, but it is a benign lymphangioma, and the current treatment is either injection of bleomycin or you can simply vaporize these lesions. This patient has actually undergone vaporization of this lesion using a RF electrode. You can also use carbon dioxide laser. That's one more vascular lesion, that is pyogenic granuloma or exuberant granulation tissue. This is following a buccal in a RD surgery. 7 or 8 months later, patient presented with spontaneous conjunctival bleeding, and in the inferior fornix he had this hidden lesion. One more vascular lesion which is extremely rapidly growing in an immunocompromised individual is a Kaposi's sarcoma. Now, tumors of the ocular surface in the next subgroup can have this orange appearance. It's very typical with spontaneous bleeding within the lesion, and that has apple green birefringence on histopathology, and that is amyloid. So amyloid can be in the medial conjunctiva in the plica area. It is rare in the bulbar conjunctiva, but more common is the amyloid in the palpebral conjunctiva. This is unilateral palpebral conjunctival amyloid, not generally associated with systemic involvement. Last is the lymphoid tumor. Now, lymphoid tumors or lymphoproliferative lesions can be further classified as benign reactive lymphoid hyperplasia, atypical lymphoid hyperplasia, and lymphoma. They all look similar. They can be misdiagnosed as episcleritis, etc. The color is uniformly pink. Irrespective of what it may be histopathologically, color is not going to help you, configuration is not going to help you in diagnosing one from the other. So you have to do a biopsy to confirm the diagnosis. Now, let's very quickly go on to management. I have about 15 minutes. Ocular surface tumors, as I mentioned earlier, have a high rate of local tumor recurrence, and that is not to be because the management is very simple. So if you combine your surgical skills with oncological principles such as accurate diagnosis, objective assessment of the extent of the tumor, neoadjuvant chemotherapy when required, margin and base clearance, and adjuvant therapy when required, the chance of local tumor recurrence can be reduced to less than 2%. Surgical excision is the standard of care for ocular surface squamous neoplasia and melanoma, but what is emerging for OSSN is topical treatment. Now, if you're asked what are the drugs that are used, there are two chemotherapy drugs, mitomycin and 5-fluorouracil. Cidofovir is specific, so we don't generally use it so often. But what is current favorite is interferon alpha 2b. So this is chemo, this is immunotherapy. Now, what are the indications? There are three variants in treatment. One is immunotherapy, where you want complete tumor control. Immunoreduction is to reduce the size of the tumor so that you can do a minimal surgery. Immunomodulation is to enhance the local immune system milieu so that the patient does not have new tumors or recurrences. Now, if your patient has corneal OSSN, like this patient has corneal OSSN, you can treat it with topical therapy. This is very good because then the patient will have preservation of vision. You can see this patient had a biopsy from this area by a cornea specialist before he sent the patient over to us. Now that is the exact area where there is a residual corneal scar. So advantage is that in the area that is treated with topical therapy, there is no corneal scar, thus the patient can have good vision. So patients like this, where there is corneal OSSN involving the visual axis, you try to treat them with topical therapy. Or for small tumors like this, there's no point taking the patient for surgery. If it's a 3 or 4 millimeter tumor, you can as well use topical treatment and the patient has relief. The third is a large tumor where the limbal involvement is more than 6 clock hours. Ocular surface specialists will tell you that if you destroy limbers for more than 6 clock hours, then there's a high chance of limbal stem cell deficiency, and to prevent that you can use topical therapy, and these patients have scarless healing. Or the fourth indication is a diffuse placoid tumor, where, as I said, the thickness of the tumor is less than 20% of its total diameter. So if you have a diffuse tumor like this, then use topical therapy, you will have gratifying results. In fact, they respond better than treating nodular variants. Or if you have a precarious corneal graft, like this patient with xeroderma pigmentosum had a graft which has failed thrice. This is the fourth graft, a very precious graft for this patient. And in the graft host junction, patient has developed a OSSN. So use topical therapy and it is gone. Or for diffuse OSSN like this with bulbar and palpable conjunctival involvement, use injection interferon. So this patient has received multiple injections of interferon and the tumor is gone. This happens in about 50% of patients. Next is immunoreduction. When you begin with a large tumor like this, if you want to reduce it to a smaller size like this, you can use topical therapy so that you can do surgery only for the residual. Third is immunomodulation, where a patient has systemic predisposition. You can use topical therapy so that these patients don't develop recurrent tumors. So what's important in topical therapy is a good case selection. There are advantages of topical therapy and surgical therapy. We know about it, but we have to choose a right candidate for surgery. Now, when you talk about surgery in ocular surface tumors, it always means excision with 4 millimeter tumor-free margins. Frozen section is not possible for conjunctival tumors. And the corneal epithelial component you excise with what is called keratoepitheliectomy, which is assisted with alcohol. That means you apply alcohol to the involved corneal epithelium and you scroll off the epithelium from the Bowman's membrane without disturbing it. Lamellar keratectomy and sclerectomy are generally not performed unless the tumor is involving corneal stroma and the sclera. Cryotherapy to resection edge is mandatory. Now, this is the kind of surgical planning that we make. We make a large diagram of the conjunctiva on a large A4 size paper, indicate each part of the tumor and what is to be excised. We also do a preoperative imaging to know the depth of the lesion. And surgery itself is very simple. This is a small lesion that I'm showing where surgery is being performed. You can see that we are marking 4 millimeter away from the clinically distinguishable edge of the tumor using a bipolar electrode. Then we are excising the lesion using a monopolar RF electrode. You can use blade and scissors for sure. There's absolutely no problem using any of the instruments. And you hold the non-involved edge of the conjunctiva and dissect the base of the episclera under visualization. As you reach the limbus, you leave the tumor there and cauterize the limbal dilated feeder vessels and apply absolute alcohol to the leading edge of the tumor for about 20 to 30 seconds until it turns subtle gray. Then you scroll off the corneal epithelium towards the limbus. That's the corneal epithelium being scrolled off towards the limbus without disturbing the Bowman's membrane, which is very important. Otherwise, Bowman's is a barrier for the tumor to get into the sclera. And if you destroy Bowman's, then the patient may come back with a tumor recurrence in the stroma. So you come to the limbus after having scrolled off the epithelium. So we reach the limbus from the conjunctival side. We have reached the limbus from the corneal side. Then the last bit is to excise the tumor off the limbus like this under visualization. So I completely excise the tumor now, but if there is a area where there is intraoperative suspicion of deeper involvement, you have to cryo it. But edge anyway is cryoed. Use a 3 millimeter cryoprobe, drape the edge of the conjunctiva around it and cryo it twice over. So it's a double freeze thaw cryotherapy of the excision edge. The entire excised edge is cryoed twice over. And the base cryo in the area where there is clinical suspicion is also performed. That will be the next step. After completing this cryotherapy, you go to the base and that is cryoed if there is clinical suspicion of base involvement. And finally, you repair the ocular surface using either conjunctival autograft or an amniotic membrane which is glued into position and trimmed to shape. So that is the end of surgery, and these patients heal very well because you have relaid their ocular surface, and the results are quite gratifying as you see here, irrespective of the size of the tumor. Even conjunctival melanomas of various sizes can be easily excised and gotten rid of. But if there is a scleral involvement like this, then you have to do plaque brachytherapy for the scleral component. That's an adjuvant procedure. So basically you tailor your adjuvant therapy depending on what the histopathology tells you. So it is histopathology guided adjuvant therapy. For example, if the resection edge is positive on histopathology and it's only dysplasia and carcinoma in situ, you have to do nothing if you've already done cryotherapy to the edge. If the resection edge is positive and it's invasive squamous cell carcinoma, then medico-legally at least you have to re-excise it. If the resection base is positive and if it's only 1 clock hour or 2 clock hours, you can cryo it. Whereas if it's diffuse, then you have to bring in plaque brachytherapy. So it's histopathology guided adjuvant therapy. Plaque is very useful. Example are patients who have scleral invasion like this. This patient has scleral invasion. Earlier we would enucleate them. Now you simply have to excise it flush with the rest of the normal sclera, and for the base you do plaque brachytherapy. So it works very well. As you see here, this is again a patient with scleral invasion treated with plaque brachytherapy. This is secondary plaque brachytherapy after confirming scleral invasion on histopathology, works well. But if it's a primary plaque brachytherapy, like this patient has a partial corneal melt, you cannot excise this tumor without compromising on ocular integrity. So you place the plaque right on top of the tumor and it again behaves very well. So plaque can be performed primarily or secondarily, as you see in these patients. So this was a patient with diffuse multifocal melanoma where we knew that there was scleral involvement on imaging. So this is how I think I can show this video very quickly. We can mark the edge of the tumor. This patient also has a PAM component. So we are now using a bipolar RF guided excision of the edge of the lesion. It was involving the lateral rectus muscle. So we are excising off the lesion of the lateral rectus, and also a bit of the lateral rectus is excised, which was infiltrating the tumor. That's the PAM being excised, and the phonesis very carefully checked under microscope. Then we apply alcohol for the corneal epithelial component and excise it, and the muscle is now reinserted back to the sclera because it was part of it was excised. Then the bed of the tumor where the sclera was involved was treated with radiation, and after exposure of that particular area, the plaque was reversed for coverage of the rest of the area of the bed, and the H cryotherapy is finally performed and the ocular surface is repaired with amniotic membrane. So this is how the patient looks 6 months later. There is no residual tumor and the patient has excellent vision because we haven't harmed his cornea in any way. So patients who have extensive lesions, obviously with orbital extension, etc., need orbital excision. And what is relatively new is the role of sentinel lymph node biopsy, especially for melanoma. If you want to know whether there is any microscopic invasion of the regional lymph nodes, and you can do sentinel lymph node biopsy. Last bit is about target therapy. For conjunctival lymphoma with the orbital component, you can definitely use radiation, but short of it, you can excise the conjunctival component and you can use peribulbar rituximab, multiple injections to get rid of the orbital component. So this patient was treated with multiple injections of rituximab. So we avoided radiation. Now for conjunctival melanoma, we have target therapy. Since the mutational spectrum has all been worked out, for each category, there are drugs. These are monoclonal antibodies. And there are reports that are appearing in the literature. These are approved for regional lymph node metastasis. So if a patient has regional lymph node metastasis, you start on this particular drug. Now, consequently, if the patient also has a conjunctival tumor, that also responds well. So we have examples of conjunctival tumors responding well to systemic therapy. This is our own patient where the patient was on nivolumab for regional lymph node metastasis, and the conjunctival tumor, recurrent tumor that he had also completely disappeared following this treatment for 3 months. So in summary, I would say that ocular surface tumors have a very high chance of local tumor recurrence, the malignant ones, and high regional lymph node metastasis. But with the surgical protocol that I suggested, there is less than 2% chance of local recurrence. So in conclusion, ocular surface tumors have a very wide spectrum. Diagnosis is clinical, aided by imaging. Surgery is the standard of care. Topical therapy has specific indications, and plaque brachytherapy has excellent prognosis for scleral invasion. And we have to apply oncological principles along with our surgical skills to get the best results. Thank you so much.
Thank you so much. Anybody has a question, you can unmute and ask directly, or you can write in the chat box.
Doesn't look like.
No questions. Obvious.
The presentation itself was so good, there's nothing much to ask.
So the reason I asked sir to talk on this topic is because of this. He had 248 slides, if you saw. Covering 248 slides in 1 hour is a humongous task. And the way he uses his pen and delineates the lesions for people. So the first time I heard him talk on ocular surface is when I thought that whenever I get an opportunity to hear him talk, I will give him this topic. Beautifully explained, sir.
Thank you, sir.
Oh, very, very nice class, sir. Thank you.
Thank you. Thank you,
Thank you
Satyajit.
so much, Dr. Honavar. This is going to go on the YouTube also, and it's going to go viral. Postgraduates are going to be watching this all over the country, and there are postgraduates watching it abroad also. So this is going to be a big boon, and I think it's not only for the postgraduates, even for consultants, this is going to be a very handy video to revise and know about different diseases which you have explained. Thank you so much for your time and effort that you have given us. The
Thank you.
postgraduates throughout the country are so blessed to have listened to you. Thank you so much, Dr. Vikas, for being with us. Thank you so much, Manishji and Intas Pharmaceuticals for bringing this together. Thank you so much once again to all the postgraduates who were here, and in future they will all see on the YouTube. Thank you so much, Dr. Santosh. We are very, very, very grateful to you. I know
Thank you
how
so
busy you are, and I know how so many works you have, but we are very, very grateful to you. Thank you so much.
Thank you.
Thank you, sir. Thank you.
Take care. Stay safe. Bye.
Thank you so much.